Okay. Hello, everyone. Thank you for joining this webinar on primary progressive aphasia. So it's also frontotemporal dementia awareness week, which I did not plan to do this webinar on this week. That was just a coincidence, but it's a good coincidence. It makes me feel like I'm right where I'm supposed to be. So we will go ahead and get started here. Introduction. My name is Holly Ambrosi. I'm a speech pathologist and owner of a private practice in Colorado called Peak Speech Therapy. I've been a therapist for 11 years now. I've been in practice since 2017, and I've worked in a variety of settings. I've done adult home health, outpatient, skilled nursing. I've worked on a psych unit. I've done some prison evaluations, and then I also work with kids still. I do early intervention and pediatric home health. I specialize in alternative and augmentative communication, so I help fund those speech devices and teach people how to use them, including those with PPA. And my love for aphasia and speech pathology, really, anything neuro-based, started in my early 20s. I also had a lot of communication issues myself when I was younger, so I just really empathized and related to people who knew what they wanted to say but couldn't quite get it out. Learning objectives for today. I hope you can walk away with a basic understanding of PPA and the variants, know the scope of the speech therapist's role in treating PPA, understand 5 problems those with PPA and their families are seeing with communication and therapy, identify 5 solutions to these problems, and name 3 treatments that are evidence-based. Also, just some housekeeping information. After the session, I will send you an email with a link to the recording of this. And in that same email, you will see a button for professional development, and you will fill out that Google form and receive your certificate within 24 to 48 hours. All right, communication. What is communication? This is a very generic definition I found online. So communication involves transmission of verbal and nonverbal messages. It consists of a sender, a receiver, and a channel of communication. So the vision of having someone communicate is much more important in therapy and in life than a rigid outcome of having someone speak. So for example, I also work with early intervention kiddos, and sometimes the parents, they get so focused on their kid talking as opposed to communicating. So I would rather someone communicate their need through any mode of language they have available. So sign language, pictures, pointing to a word, rather than becoming frustrated and losing their ability to express their needs and wants and ideas. So why is this important? It's to expand your definition and awareness of what communication is, so you can see the bigger vision here for many people living with PPA. I also want you to consider who the sender and receiver is if someone is relying on someone else for communication. So if someone has to interpret what you're saying and they help you put a sentence together, who's the real sender of that message? Also, the channel of communication, is that only talking? Could it be other modalities like pictures, signings, gestures, nonverbal cues, an AAC device? So that's just to kind of get you thinking. All right, what is PPA? I like this definition from aphasia.org. It says PPA is a neurological syndrome in which language capabilities become slowly and progressively impaired. Unlike other forms of aphasia that result from stroke or brain injury, PPA is caused by a neurodegenerative disease such as Alzheimer's or frontotemporal dementia. PPA is characterized as a young onset dementia. And language deficits occur in the absence of other cognitive or motor impairments. So, when we often think of dementia, we think of memory loss, and that's probably because Alzheimer's is the predominant dementia out there. So, in this case, memory loss is not going to be that primary symptom. In many definitions and diagnostic criteria of PPA, you will see it says PPA occurs in the absence of other cognitive impairments. And this is not always the case. However, in order to be diagnosed with PPA, the neurologist will be looking to see that language is one of the primary or first symptoms you have initially. Okay, moving on. Dementia is the umbrella term here. So there's many types of dementia. So far, the 3 variants or subtypes of PPA are stemming from 2 types of dementia. That is frontotemporal dementia or Alzheimer's. And the variants include non-fluent agrammatic, semantic, and logopenic. Eventually, there may be more than 3 PPA subtypes, and even now, many people don't fit snugly into one of the subtypes. A neurologist is the one who diagnoses PPA, and they look for patterns of a brain disease using functional imaging like PET scans, MRI. They may do a spinal tap and look at cerebrospinal fluid. They're also looking at the case history, symptoms of the syndrome, and that's why speech therapy and assessment is so important. That's why we're getting a good case history and interviewing people who are also living with the person with PPA. Because the person with PPA may not have the insight into what's going on as well. So a neurologist may diagnose PPA as unspecified too, so they may not be able to type it into one of these 3 subtypes. And that's if they're not seeing maybe a clear underlying brain disease going on. So maybe that the brain atrophy isn't showing up on an MRI yet. The criteria of each subtype or the primary symptoms in each is subject to variation and overlapping symptoms. So that could also lend to a PPA unspecified diagnosis. And there are other variants of FTD like behavioral variant that will have some language issues too. The first variant here is non-fluent agrammatic PPA. I've listed the core features, and I'll talk a little bit about each. Apraxia of speech is a motor planning issue. So that's issues with programming your speech movements. So that's like the blueprints of what we want to say are getting messed up from the brain to the mouth. Dysarthria you will see as well, and about 40% of people with this variant, about 40% have dysarthria. And this is musculature problems like weakness or inability to control the muscles used in speech. So you might see slower movement, varied movement, sound substitutions, prolongations. You may see someone's mouth trying to get the words out. There will be agrammatism. That's the third feature here. So that means there's a lack of grammar in expressive language, but also difficulty understanding grammar. So more complex sentences, longer sentences, complex directions are going to be difficult. And if you're thinking about, if you have an issue with expressing language, you're only going to get those key words out to get your message across. Grammatical deficits can occur across modalities as well, like writing and reading. So you'll get more movement disorders with this variant as well. Eventually, it could turn into a more global motor disorder like progressive supranuclear palsy or progressive apraxia of speech. Someone with this variant, their speech is not going to sound natural. There will be more effortful, and telegraphic speech prosody. So with this variant, the problem is not as much of like word retrieval issues as it is the movement. So there's more difficulty with the motor planning and coordinating speech. And you also may see more deficits in executive functioning. Executive functions are what helps us get things done. So our cognitive skills like multitasking, initiating, planning, thinking flexibly, problem solving. You may also see some neuropsychiatric stuff like apathy, depression, anosognosia, which is that difficulty with insight. So having insight into your own deficits. Semantic PPA, this one is very different. It will look different than non-fluent. So this person who has semantic PPA may be talking very fluently, but the content may seem vague or empty. So they'll use more pronouns like it, that, those thingies. So the areas of the brain that store conceptual representations or meanings of words will be affected. So we have these toxic proteins, TDP43, they're just running amok in that area of the brain that houses all of our concepts. It's disheartening. So there's this progressive degeneration of word attributes and specificity. So it's almost on a continuum. So for example, maybe someone is really good at naming types of birds. So they might say, oh, look at that hummingbird out the window. But a year into this diagnosis, they may not call it a hummingbird, they may call it an animal. And a year later, they may not have that concept of an animal anymore. So those with semantic PPA are not only showing a loss of semantic or word knowledge, but it also disrupts their ability to learn, acquire, and store new knowledge. That's affected as well. And I'll go into ways we approach this. The third variant is called logopenic PPA, and this is under the Alzheimer's dementia. And this one is harder to differentiate from that first variant I talked about, non-fluent, because you're going to get a lot of pauses in this one too. So it might sound very telegraphic with limited rhythm. But this one's not due to a motor issue. It's due to anomia, which is a true word-finding difficulty. They're also going to have issues with their phonological loop or their working memory. So a good example of the phonological loop is if I were to give you my phone number, you could probably remember those 7 numbers or say them out loud and remember them. Someone with an impaired phonological loop or working memory may only remember the first 3 numbers. The people in this category will also have difficulty with phonemic awareness skills. So phonemic awareness skills, those are our ability to, they include our ability to rhyme, be able to segment and blend sounds that helps us decode words. So if someone's having difficulty with phonemic skills, as the SLP, as a speech therapist, giving them a first sound cue or a rhyme cue may not be beneficial. You know, you're saying, oh, well, it rhymes with bus. And they're saying, I don't care because that doesn't mean anything to me. People in this category also have phonemic paraphasias. That is a substitution of one sound or a couple of sounds in a word. So a word may come out similar to the intended word. For example, puddle for puzzle. You will also have difficulty with repetition. So being able to repeat back a sentence, which makes sense if their working memory and phonological loop is having challenges. All right. So one strategy, talking with someone who has logopenic PPA, a strategy you could use would be to shorten your sentences. right? Or exaggerate keywords in the sentence, or give them visual cues for following a direction or step-by-step sequencing images. And you can do those on an AAC device, or you could print them out. You could use them on your phone. So word finding difficulties, or anomia, is different from the semantic variant that we were talking about, the second variant. Semantic variant is concept loss. They're losing the idea of what a phone is. This is more of an issue of retrieving the word they know they want to say. So they know the concept. Oh, what is that thing? They know that we use people, but they just can't find that word phone. So we would give them other modalities to express themselves in this variant, such as an AAC device, pictures, written cues might help. Again, you're going to have issues with grammar in this one. And this is the Alzheimer's variant. So there will be evolving language, cognitive, and motor deficits. You'll see more visual spatial issues in this one. So refer out to occupational therapy or physical therapy if needed. So do you see how a symptom can present the same across all three variants, but the reasoning behind it may be different? So that's critical to know so that we use the right treatments for each person. So someone with non-fluent PPA may know the word, but they can't physically say it because of motor issues. Someone with logopenic may be able to picture the object, but they can't find the word because of anomia. And someone with semantic PPA may not have that concept anymore. Problems. Let's go into problems we're seeing. Many clients and their families are unaware of this diagnosis, how to explain it, how to plan for it. PPA is a disorder that is more recently recognized, and typing the PPAs into subtypes is an even newer concept. So some people are getting a diagnosis up to 5 years later than when they need to, or they're getting an incorrect diagnosis, like a psychiatric diagnosis. And this is due to just general lack of awareness about this syndrome. And additionally, there's difficulty in establishing when the disease onset occurred because there's no acute episode happening like in a stroke. So seeking care is determined by the individual or encouraged by their support network. And it's also determined by individual differences, perspectives of our healthcare system, variability in symptoms, and access to resources. So all of that impacts someone's ability or desire to seek care. And I think people get diagnosed later because this is a younger person's dementia and people brush it aside. They say, I'm only 58, I'm fine. There's a lot of cognitive reserve happening in those beginning stages, so the person with PPA may hide or mask their symptoms. The second problem, access to services. And by services, I mean speech therapy. So a referral to speech therapy should be made before someone gets a diagnosis of PPA. And oftentimes, people are not getting referred to speech therapy for several reasons. One, there's uncertainty about speech therapy treating a progressive disorder. So some doctors may not refer out. And some with the diagnosis may not be seeking a referral or know that they need to advocate for that. There was a research study done by Ruggero et al. In 2020 that said the actual number of people with PPA referred to speech therapy remains low. Access to services is challenging for other reasons, such as financial. I mean, the American healthcare system, lack of insurance reimbursement, high copays, high out-of-pocket costs. Another barrier to services is physical location. If someone's in a rural area, there may not be enough adult speech therapy practices or clinics to go around. And if there are, those therapists may not have experience with PPA. Third, once someone is in therapy, it could be limited. Therapy might end too early due to insurance caps, or maybe they just have one speech therapy episode and no follow-up. So people with PPA and their support networks, they need that follow-up, and they need multiple cycles of therapy because language changes and possible cognitive or behavioral changes are starting to increase as time goes on. So being able to keep an open line of communication with these people would be very helpful. And a lot of therapists don't feel like we can get just medically reimbursed for this. So we can get reimbursed for medically justified therapy. Maybe you've never even heard of, and I'll go into some of this. And this includes therapy in the middle to later stages as well. I am not an insurance expert, but I am a Medicare and a Medicaid provider. And I'm sure a lot of adults out there have Advantage plans, which follow Medicare guidelines. So what I'm about to say should be applicable to many people with Advantage plans too. So to justify speech therapy for someone with PPA under Medicare, you need to emphasize that therapy is essential for maintaining function or preserving function as long as possible, not just improvement. And that's exactly what speech pathology research has shown. And think about it, in a disease that you should be declining, being able to maintain is progress. The fourth problem, ineffective therapy. So the strategies the SLP or speech therapist is using may not be effective. And this could be due to lack of knowledge about the diagnosis. It's probably a well-intentioned, intelligent speech pathologist giving you information that was maybe not the most appropriate for the specific person's variant. Maybe it's no longer appropriate because their symptoms have evolved. Maybe the neurologist never even gave them a diagnosis to work with. So they're kind of running blind through this. 5, limited research. PPA needs larger research studies. There's so much research on aphasia post-stroke. It can be difficult. And that's because it can be difficult to evaluate treatment outcomes in the context of language decline. So like I said, little or no improvement may be a positive outcome when worsening of skills is expected. So that could affect research as well. So let's take all those problems I just reviewed and think about the effects of those. If you're not getting a therapist who knows what they're treating or the diagnosis yet, you may be getting an unrealistic expectation or getting treatment that's not beneficial. This creates adverse health conditions. Some with the diagnosis may not be seeking a referral and losing out on this time, this precious time they need to help stave off decline. So then the PPA progresses quicker. And then all the feelings I put there, grief, anger, hopelessness, fear, uncertainty, those are all understandable and valid in a diagnosis like this. Solutions in speech therapy. So we need to have good assessments and good case histories. We're not just evaluating words, but we're asking about cognition, and we're talking to spouses and family members, friends. We're asking, hey, have their eating habits changed? Has their mood changed? Are they having behavioral changes? We're using more person-centered assessment as well. So we might include maybe a picture of their family for a language sample instead of using like an outdated arbitrary picture like the cookie theft photo for you speech therapists that know the cookie theft photo assessment. So we're using person-centered assessment. We're talking about hobbies and life goals that they want to achieve and continue to do. Sometimes the characteristics that are unrelated to language are the ones that can help parse out the type of PPA as well. And more importantly, the underlying brain disease. And that's important because you want them to get accurate therapy for whatever brain disease they have. Or medicines. Neurologists have specific medicines too. So people may put off getting a referral or getting the right referral. This is the next one, number 2. Speech therapists need to be providing education to the public and our clientele on when we get a referral for word finding deficits. So that's another one. I know a lot of older people in my family have asked me, is it bad that I'm struggling to find my words? So that's a big concern for older people. And the more we can educate, maybe we'll catch some of those PPA diagnoses earlier on. Number 3, I have people track symptoms. So in every home exercise program I write, I say, get a cognitive journal or a notebook and start tracking any symptoms, any word finding deficits. Number 4, education on understanding the disease or the diagnosis of PPA. Sit down with your clients and ask the families, what do you know about this? Say, hey, I was looking at John's neuro reports and it said he got diagnosed with semantic variant PPA. Do you know what that is? I'll tell you, a lot of times they will say, no, I don't know what that is. It's almost like they've never been told, or maybe, I don't know. I mean, neurologists are super smart. I'm sure there's great neurologists explaining this to their clients, but a lot of my clients that I've seen have not had it explained to them or provided to them in like a multimodality format so that they understand. The next solution is, so this goes under education, provide realistic expectations. So being clear is kind. Telling someone the truth in a compassionate way, as long as they're asking for the truth, is what needs to happen in this diagnosis. And this way we're giving them a voice in what their future looks like, and they can help plan their future. Number 5, having multiple episodes of care, if appropriate. We're using a consumer-driven model of intervention where we're focusing on the individual with PPA's wishes on how they want to be able to participate in life and their life goals down the road. Okay, so this naturally lends us to have more frequent, shorter, and efficient speech therapy episodes to target goals with them, even in the later stages. And there's naturally going to be more than one speech therapy episode if someone has evolving symptoms and changing family roles and dynamics. I'm not suggesting Medicare should cover therapy for 10 straight years. I'm saying once symptoms are significantly changing and prior strategies are no longer effective and they aren't participating in those life activities, we pick them back up and address new strategies and treatments to help them reach that bigger vision of connecting. Number 6, SLPs, speech language pathologists, becoming more well-versed in evidence-based treatments and assessments for PPA. So that's a solution. I think a lot of the current therapies and evaluations do not address the progressive nature, and I'll go into some of the therapies in a few minutes. And then lastly, we need to be writing our goals to be a mixture of compensatory and rehabilitative. Our scope of practice is so broad. So we treat swallowing, cognition, respiration, speech language. You might see swallowing issues in the non-fluent variant down the road because that's that motoric piece. They're having difficulty with motor skills. So a speech pathologist can help with that as well. Alternative and augmentative communication, or AAC. This is a specialized field within our field. So we acquire, fund, program, and teach people how to use speech devices, which I have done with PPA, and it's very helpful. Caregiver training. We do lots of training with communication partners. This should be a part of our therapy with PPA. And it's now reimbursable by Medicare, which is so nice. And the patient does not have to be present for us to get reimbursed by Medicare, if you didn't know that. Evidence-based treatments. I'm only going to go into a few of these, but I just wanted to show this slide so you know how many therapies are out there that can help make a difference. Some of these may work better in the early stages, and some like nonverbal cues or AAC with voice banking may be used later. But no matter what, the earlier you get started, the better the outcomes. And so we're using a life participation approach with all of these therapies. So for example, we're taking activities that these people want to be able to do in life, and we're practicing their communication in those activities using these interventions. So let me explain that. For example, we may be using, so number 3 here, lexical retrieval cascade. Maybe we're using that cueing hierarchy during a coffee FaceTime with one of their friends, okay? Or maybe we're doing voice banking, this last one, so that they can still sing in their church choir, maybe when they're 5 years into the disease and they're losing their voice. So we're making goals functional for their everyday outcomes. And research shows that therapy versus not having therapy is beneficial in slowing the progression. So we have that evidence. I'm going to go into these 3 a little deeper. So communication partner training, this is such a cool idea. I didn't come up with it. It's an evidence-based approach. Mara Silverman, I believe, was the originator. So this is a therapy where this is not a communication support team. I'll go into communication support teams in a minute. Communication partner training. This is different. This is a therapy where you are evaluating not just the individual with PPA, but you're bringing in their communication partners, and you are observing and analyzing how they connect in conversation. So you may have a list of facilitators that help improve communication with that person, and barriers. So maybe a list of things you're doing in conversation with that individual that is not helping them communicate, like interrupting. And you can do this a few different ways. The Better Conversations approach uses video. So you can actually video yourself having a conversation with the person with PPA. And then afterwards, you watch the video and you check off what facilitators and barriers you are using. And I like this approach because it gets us holding ourselves accountable and shouldering the weight of the communication repair. Because I don't believe the person with PPA should have that responsibility of shouldering the weight of the communication repair. If they can use strategies, great. I recommend that. But that should be more on us, the ones talking to them. How can we improve this conversation? The next one, alternative and augmentative communication. So this is an evidence-based therapy, and it's also a mode of communication. So it can help someone still participate in conversation, even if they don't have the words. You can really personalize these devices. You can put pictures of family members on there. You can put their own voice on there. It can be used as a photo memory book that talks. It's also great just for conversation to have, because you have a robust language system with tons of pictures that they can use to express themselves. It would be wise to offer this as an option early on for families, so that allows them to decide if that's a route that they want to take and we can start teaching them early how to use it. AAC does require specializations from a speech therapist. So knowing how to obtain the device, fund the device, or provide low or no cost out-of-pocket options. We also help program and train the person and their family on how to use it. This requires some sophisticated therapeutic approaches because it's a delicate balance. We don't want to overwhelm them, especially with technology, but we also don't want to ignore this intervention that could really help. And I offer a free AAC bonus lesson in my PPA course that I will discuss at the end. And that lesson goes in depth into the apps and softwares and devices in addition to funding. And if you are a speech therapist, you should check out visual scenes. Visual scene displays are great for this population. It allows you to take a picture from like a scene in their environment, like their kitchen, and you can add little hotspots on the screen that they can touch. So for example, on their cabinet on the screen, they could press the button for it and it would say, I want my coffee or something like that. So it becomes very meaningful. All right. And then the third one here, the communication support team. This is what I was talking about earlier. Mara Silverman, I believe, was the originator of this. This is where a speech pathologist helps recruit and train a group of people to assist in language and activity supports for those with aphasia. So these can be neighbors, family members, volunteers, coworkers. And the purpose of this is to decrease isolation in the person who has PPA. It naturally promotes additional hours of communication practice, which aligns with neuroplasticity recommendations. And it provides support partners, so the communication partner, with a purpose and a means to communicate and connect with the individual. Because many times people say they want to help, but they don't know how to. And then lastly, it reduces stress and full dependency on one person or one caregiver. And you can create a communication support team on like a free sports teams website. So I actually did this a month ago. It's easy and it was fun. Okay, so our role is somewhere in all of this. We're managing symptoms. We're keeping an open line of communication. We're helping people navigate this. And we're supporting the individual with PPA and their families by listening and including what their visions are so that we can preserve their personhood. So we don't just have rigid outcomes, we have vision, bigger visions for them. And the rehab bubble there is some rehab happening. So neuroplasticity is happening on imaging to an extent. There was shown to be increased brain activity in the left anterior temporal lobe in patients with semantic dementia after speech therapy intervention. So we're getting some rehab in there too. Our goals are a mixture of outcomes and visions, and the outcome may eventually change to a vision as the disease progresses. So early to middle stages, an example of an outcome may be for someone to say the name of their family members while reading it in a script. So that's a clear, definable outcome. In the middle stages, this may eventually move to a different outcome, such as communicating their loved ones' names in a different modality, like using an AAC device. And in the later stages, that's where we see more of the vision of connecting. If this were my parent, my vision would be for them to live joyfully and peacefully and communicate in a way that works for them, as opposed to holding on to that outcome for them to say words with their mouth. And once they're in that later stage, they can't learn their way around this, and we can't teach our way around this because now there's other cognitive domains impacted. So then we look at adapting the environment. We may get an OT, occupational or physical therapist on board. We use more non-spoken communication. We use those communication support teams. We use AAC devices. We're preserving their personhood. Okay, and then this leads me into preserving personhood. So we're going back to that original slide about communication. Remember that slide? What if the strategies aren't working anymore for retrieving words? And what if they are showing other cognitive and behavioral symptoms? What will this look like years down the road? And you know what words kept coming up for me over and over in the research and listening to people's voices with PPA? Personhood and humanity. And think about it, if we connect with other people through how we talk, through talking, we are going to start to feel like we're losing ourselves. So, how can we view communication in other ways to preserve one's personhood? Well, activity-based groups that do not focus directly on talking may also be beneficial for individuals with PPA. And research has shown that participating in hobbies like gardening that do not require talking have actually reduced frustration and improved mood. We may do project-based interventions. So this is where you help the person with PPA plan out a project that could benefit others or connect with others in the community. And we can still connect with them in nonverbal ways. We can hold hands, we can listen to music together, we can observe their signals and signal those back to them. So, what inspires your own humanity? For me, it's when I connect with other people or something bigger than myself and my emotions feel validated. So we're doing those things for others, for those individuals with PPA. And I just thought this quote was really beautiful. And I also want to provide a hopeful note. So those with PPA and their families, they're looking for stability and support in the face of a terminal condition. And there's limited resources right after they get the diagnosis. But there are resources out there. SLPs need to be here to provide solutions, which include quality treatment in all periods of the diagnosis, educating them, acknowledging their emotions and their personhood, and referring out when it's appropriate. I think it's hopeful that there's more awareness now. There's access to telehealth and podcasts and YouTube that can talk about all this. And there's more research being done on disease-modifying therapies, and you can enroll in clinical trials. Here are some resources. The Mesulum Center, they do have a support group for care partners, so you can go on their website. And I believe they're starting 2 new groups in January. I don't know if they're virtual, though. They didn't get back to me on that. The AFTD website has great resources. The National Aphasia Association has PPA chats. So those are virtual. Consulting, if you can't find a therapist, maybe see if someone will do like a one-time consult. I offer consulting as well, but my consulting fee is much more than what I'm charging for my connections within PPA course. So if you're interested in that, here's another solution. This is a 2-hour and 15-minute guided video course taught by me. You'll discover how to use speech therapy approaches in everyday scenarios to feel more confident in communicating with someone who has PPA. In addition to learning how to tailor your communication in the different stages of PPA and the different subtypes. So you'll learn how to obtain and implement an AAC device at home through a free in-depth AAC bonus lesson. So you get that lesson for free if you sign up by 10/4. You get all the handouts to download or print, and you can use those in a clinic setting or at home. Professional development is offered. So the downloads will be available on October 18th, along with the first module. And then you get the rest of the modules on November 1st. So if you're interested in learning more, you can scan the QR code. I will also put the link in the chat. So I'm going to do that now. Okay, so that's the link to the page about the course if you would like to learn more. And then anyone that signed up for this webinar, there will also be information and links in a follow-up email as well. I really hope this was helpful. If you have any follow-up questions or feedback, please email me. I would love to help. Thanks so much.